Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AOSSM meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. OSSR prides itself on creating effective, non-invasive bracing solutions focused on orthopedic, osteoarthritis, and injury care. With a long-standing commitment to serving medical professionals and collaborating with leading orthopedic research institutions, OSSR maintains a strong service ethic, addressing the diverse needs of their customers.
Their globally recognized brands such as CTI, Rebound, Miami, and Unloader are designed to improve mobility and enhance quality of life. The Unloader 1 knee braces are clinically proven to alleviate osteoarthritis pain, while their Injury Solutions line aids in the recovery from fractures, ligament injuries, and postoperative treatments. Recognized as a technology pioneer by the World Economic Forum, OSSR advocates for life without limitations, partnering with individuals, clinicians, and communities worldwide to enhance millions of lives.
If you're looking for a trusted name in allograft transplantation and want to learn more about your allograft options, then look no further than JRF Ortho.
JRF Ortho is an innovative leader, providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they are the first to offer OCA cores available in 10mm, 12mm, and 16mm sizes for small focal osteochondral defects.
JRF Ortho also prides itself on superior customer care, making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering an osteochondral allograft around 30 days, all on your terms. So if you're tired of waiting weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner.
And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can just focus on what matters most, your patients.
So discover the only allograft company focused solely on sports medicine. Order your allografts today with JRF Ortho. Today's episode is going to focus on the workup of a patient with a suspected multi-ligamentous knee injury, as well as the surgical approach that follows, including acute versus delayed surgery, repair versus reconstruction, surgical technique, and order of operations in the OR. We are joined today by 2 outstanding guests.
Dr. Matt Provencher is an orthopedic surgeon at the Steadman Clinic in Vail, Colorado, principal investigator at the Steadman Philippon Research Institute, and assistant editor-in-chief of Arthroscopy. He is very active in academic societies and serves on the board of directors for AOSSM, AANA, and SOMOS.
Dr. Armando Vidal is also an orthopedic surgeon at the Steadman Clinic in Vail and is the vice president of the medical staff of Vail Health Hospital. He was also the head team physician for the Denver Nuggets from 2017 to 2019 and also served as head team physician for the University of Colorado men's basketball program and the University of Denver men's hockey team for 11 seasons.
So, without further ado, let's get to the field house. All right. Okay, so Matt and Armando, thank you for joining us today for a special episode of the Sports Docs podcast live within the field house. And welcome to Denver, not too far away from Vail. So welcome to the show.
Yeah, thanks for having us.
Yeah.
Thanks, great pleasure.
Awesome. So today we're going to be talking about multi-leg knee injuries, mostly focusing on the surgical side. But before we dive into that, we want to talk a little bit about your initial workup and evaluation of a patient with a suspected multi-leg knee injury. So for simplicity's sake, a patient dislocates their knee skiing, seen in the ER, successfully reduced. They present to your clinic in a knee immobilizer. What are you looking for?
Well, I mean, I think the first step is just making sure you don't have any other concomitant damage, right? Especially vascular or neurologic injuries. So, obviously getting a good exam, vascular exam, you could do ABI PVRs, you could do vascular studies, but that's where you're going to get into trouble, right? It's the surgical management is complex enough, but if you have a concomitant injury like that, you want to identify it, it needs to be treated and addressed. Most of these injuries are stable enough that they don't need to be placed in next fix. Then the next question becomes about the stuff we're going to talk about, surgical timing, what needs to be addressed. But advanced imaging is helpful. Some of these have periarticular fractures, so x-rays, MRI at a minimum, maybe CT scans if there's a question of a periarticular fracture, and then just trying to figure out what's in and what's out and what needs to be addressed.
Absolutely.
Yeah, and in addition, we did a fair amount of varus valgus stress x-rays during my time with you in Steadman. Would you, when are you integrating that? Is that a big part of your multi-lig practice?
Yes and no. I mean, it depends how unstable the knee is, what the injury looks like. Obviously, usually we'll have the MRI and be able to assess that. So some of it is just looking overall at the overall picture and doing an initial just exam on the table, and then being able to go from there to truly say how is this going to heal. And it gets in what Armando was saying, the timing standpoint, everything. But from the initial evaluation, the other things where we've gotten a little bit in trouble, and I've seen this, is it comes in to see you a week later, 2 weeks later, DVT,
Right.
blood clot. That's almost an automatic ultrasound for me. If you're more than a couple days out, ultrasound, DVT rule out. And by that point, ABIs are probably least, not as important. Maybe you still want to look at it. And then if there's any question, arterial study.
Yeah.
Yeah, totally agree. I think stress x-rays are probably better in that chronic setting. I think sometimes in the acute setting, they come in, they're so swollen,
They can't
so
tolerate.
acute. Yeah, exactly. So it's really hard to perform a stress x-ray, especially like a kneeling stress x-ray for PCL.
Yeah.
So Armando, you mentioned in terms of surgical decision making, in terms of timing, but also what you're doing. So we want to talk a little bit about timing.
Sure.
So a patient comes in, and let's say that same guy that I just mentioned as an example comes in. It's isolated, purely ligamentous, so no fractures. But he has ACL, PCL, posterolateral corner. Are you taking that kind of urgently or acutely for surgery, or are you advocating for more like of a delayed reconstruction to give them time to get their motion back?
This is a great question, right? And this is like one of the big controversies right now in multi-lig, which is acute versus chronic. I think there's an advantage in that setting to get to them early because you have the capacity and the ability to repair, right? So, and that's also a controversial time, like repair or controversial topic, repair versus reconstruction.
We'll get
And in general, reconstruction is better outcomes, but if a repair takes successfully in restoring that anatomy, I think there's a lot of value. And you're kind of time sensitive there, right? It's probably about 3 weeks, maybe 2 to 3 weeks. So if I have the ability to get in there acutely for something that I can repair, I'm going to try to get in there acutely if I can.
So Matt, I feel like you had a counter or something you were going to add to that.
No, I totally agree, but it just gets into the surgical timing and where the patient is and how much is injured. If it's an ACL plus MCL, that's multi-lig by definition, but that's a very common scenario. If it's ACL, MCL, LCL, if it's PCL plus ACL and an MCL, we're talking a totally different scenario in terms of how to manage it. If there's something I can get after early from a repair situation, as Armando said earlier, especially in the first couple weeks, stage it. Get something repaired first, come back 4 to 6 weeks later and finish the rest of the stuff up. It's a little bit of a speed bump in their overall recovery and life, but it's just way better to space this out.
So specifically, like what do you look at on the MRI that you're like, that is, those are the things I tend to go towards repair versus reconstruction and hope that you can get to early?
Yeah, so clean avulsions. A lot of times you'll have clean avulsions off the fibula for an LCL, or sometimes a bony fleck, clean avulsions proximally on the femur. And sometimes you really got to look closely at the MCL, and reconstruction is probably better if you've got a bad Stenner lesion almost, or a Stenner equivalent lesion, and you're around the pes tendons area, and you got some other problems. Or if there's a distal avulsion, which is much rarer, but usually a proximal MCL, maybe some distal or proximal LCL, popliteus. There's a few others, obviously, and also the other one is PCL avulsion off the tibia. That's a very classic one.
Makes sense.
Absolutely.
And I also like to tell the fellows, and when we talk about these injuries, and I love to use the term Matt talks about, which is SA, you got to be situationally aware, right? Because a lot of these injuries don't occur in a vacuum, right? If it's a ski injury, it may be in isolation, but some of these guys can have head injuries, they can have spine trauma, and that's going to totally change your timing, and that's going to dominate, or have a medical issue, and that's going to dominate. Sometimes it's out of your control.
Yeah, I think fair point.
So you talked about associated injuries kind of outside the knee, but there's also a high rate of associated injuries in the knee, right? Meniscus, cartilage, about 50% of the time. So at the AANA meeting, you gave a nice talk talking about order of operations in terms of a complex knee injury. Like, what do you do first, second, third? What do you stage in terms of maybe having to break it down into 2 stages versus doing everything all at once? So we did kind of want to talk to you about your order of operations. So let's say that same guy, ACL, PCL, posterolateral corner, but also has varus malalignment of 10 degrees and a cartilage injury, medial femoral condyle. Are you doing this all at once? Are you staging it, and what's your order?
Well, that's a good question. I mean, I think that scenario probably presents itself more in the chronic setting, right? So if they have malalignment baseline, like their varus, for instance, and they've got a lateral side injury, and it's an acute injury, I'm not going to touch that alignment. I think that I'm not going to go into an osteotomy and an acute injury. Now, if it's a chronic injury, or if it's a failed previous surgery or repair, then I'm going to consider realigning that leg. And in that case, I feel like the osteotomy becomes the foundation of your future work. So in general, I do the osteotomy first if it's a realignment procedure. If there's additional non-weight-bearing portions of that case that I can do during that setting, I like to do it to kind of lump that all together to make the second recovery easier. But then I'll come back and do most of the ligament work. All those cases are different, right? So like it's a different hodgepodge, and the order of operations becomes challenging. So you almost have to walk yourself through the steps of that operation. Like, where am I going to run into trouble? Where are my pain points going to be? But in general, in that case, an osteotomy will be the foundation, and then I'll come back and do things later. But again, mainly in the chronic or revised setting.
Got it.
Ashley, you talked about some of the other, the meniscus, the cartilage, everything else. It's always nice to get a second chance if you're staging at a meniscus or a first look at the cartilage, and then come back and get another chance. So I always try to repair the meniscus even at the outset if they're going to have any. It doesn't change their rehab too much. Maybe 3-4 weeks on crutches, et cetera. So, and then you can come back and maybe get another chance at the meniscus, because we know how important that is down the road. So it depends how you stage it out. But the soft tissue, the cartilage, one way to think about it. And then do you do some of the ligaments and then come back and do the last ligament? The last ligament generally has been ACL, and we did a good study in Vail. Jorge Chala did a really nice one in terms of order of tensioning, order of doing grafts, and if you do these all together. So there's a lot of controversy about this still, but there's still an order of operations that I think is important.
Yeah, I think both of you are sort of echoing the importance of just being really thorough and thoughtful with your plan, because you're not really working through every step as you go, almost like bringing yourself back to a resident where you're sort of outlining all your steps to your plan. You start to be like, oh, I didn't even think about that, for whether it be tourniquet time or position, or any sort of the nuance that mid-case can get you into a lot of trouble if you didn't think through those minimal steps.
Exactly.
Yeah, and I think that just going back on the staging thing, it's funny because it's active controversy right now, right? Yeah. Single stage versus two stage. I don't think that anybody has the right answer. Going back to being situationally aware, like, you need to know what your resources are, how long it's going to take you to effectively do one of these procedures. So there's no shame in doing it in two stages, right? I think sometimes we have an embarrassment of riches, that we've got a lot of grafts available and hands and fellows, and doing it in one stage is very effective and efficient, but you don't want to spend 5 or 6 hours in the OR either. So there's no shame in staging it if you feel like you're going to do a better job in two different settings.
Two 2-hour procedures are way better than one 5-hour procedure. And it's just at the end of the day, the rehab on that we've seen, just anecdotally, experientially, it's just way better. So don't be afraid to stage it. Another 5-6 weeks after a really bad injury like this, especially in the acute setting, not a big deal. I know it's a big deal to the patient, but it's going to be way better at the end of the day.
But in the grand scheme, and I always try and share that with patients, that it's like, we're already looking at, for a lot of these things, a year of recovery anyway. When we're adding a handful more weeks, it's really not a big deal. And I think getting that little rehab time in between, it allows them to sort of, get used to their new state and, work on their motion, get their quad activated, and it's a good thing.
Agreed.
In the chronic multi-lig knee, which, is usually, and I want to mention, we talked about, failed ACL, a failed PCL, what's the issue there? Well, it's unrecognized posterolateral corner, unrecognized LCL, maybe some MCL stuff, maybe slope, maybe alignment, maybe other things. You look at it, we have a whole laundry list and checklist we go through on that, but that's another multi-lig knee injury we're taking care of just in a chronic situation. But that's a whole nother different animal in terms of how you stage that, and whether meniscus, cartilage. But a lot of times doing that staged also. And the beautiful stage about that is, I use Armando's mantra all the time, is it's always great to get a scope in there and take a look, and then you got your plan for the real surgery. Next.
Yeah. So, Matt, you brought up posterior lateral corner. So I think that's another area where people coming out of training, that's really daunting. So if you don't have a lot of exposure to it in your fellowship or in your residency, so can you break down a little bit for listeners as far as, your technique, your steps, and how do you make sure that you're hitting all the right points and not hurting the wrong ones?
Yeah, Catherine, you know from being with us that it's a big part of our existence in Vail, and not everyone has it, but the first thing starts with just having a suspicion it's there. An ACL that's just not doing as well as you'd like, got to check the posterolateral corner. It's absolutely number one, and we're getting so much better at our tunnels, the ability to put things. Used to be tunnels the main issue, now it's other associated things, and Armando's done a great ton of work on tibial slope and other things that are contributing to this. So when you look at the posterolateral corner versus recognition, and you talked about it a little bit, do we get stress x-rays? First of all, it's sometimes I'll go back and forth on the bed, the patient lying flat, 0 degrees, there's usually no difference. It's nice, it's good, it's tight, but it's at 10, 15 degrees of knee flexion, and you're assessing that lateral side with a side-to-side comparison. And I'll go back and forth 3 or 4 times, and I'm like, okay, now let's do stress x-rays or not do stress x-rays. And stress x-rays are basically just reproducing what you did on the table in the x-ray suite. We have a little foam bump that's about 15 degrees-ish, I think, and we bend, but it's equal and same on both sides. So we put the lead gloves on, do the man max stress applied, and then we measure it on the radiographs. And we know that we can make better, and it's probably clinically significant, something in the order of 2.1, 2.5, 3 millimeter side-to-side difference. That's clinically probably meaningful, and we know from post-surgery and post-stress x-rays that we can get that better.
And Armando, can you talk a little bit about your surgical technique? Full disclosure, one of my mentors from fellowship, out of the blue, not even knowing we were interviewing, he said, Vidal has the slickest technique for posterolateral corner. You got to check it out. You got to do it. So I did watch your video. But for our
that's
listeners,
awesome.
Can you talk through what that technique looks like?
Yeah, so that's been a game changer for me. So I use suspensory fixation now. So I think one of the challenges is, and Matt alluded to it earlier, is the sequence of tensioning, right? And I always found that it's like, gosh, you tension it, and then you do something else, and then it's a little bit loose after, and you're just not totally satisfied. So I went to using adjustable tensioning devices for my posterolateral corner probably about 7 or 8 years ago. And what that affords me is the ability to tension I'll do the PCL first, right? Then I'll set the collaterals, do my ACL, let's say, if you're doing all the ligaments, and then I can go back and fine-tune it. And that ability to fine-tune is actually really, really nice. So you can provisionally get fixation and tension and then come back. So I have 2 techniques. There are 2 kind of generally accepted techniques in the literature. One is Dr. Rob Laprode's technique, which is an anatomic reconstruction with 2 tunnels on the femur, 1 in the fibula, 1 in the tibia. And then you have Arciero's technique, which is a fibular-based reconstruction. I do both. And the way I make a distinction about which one I'm going to do has to do with whether or not they have tib-fib instability. So if they have tib-fib instability, it's probably about 30% of multi-ligs do. Then I don't like anchoring solely to the fibula because it's you're anchoring to something that's loose. And this is something that I learned really from Bruce Levy, and he learned from Finelli, is that if they have asymmetric hyperextension, they also need that band around the back. So if they have either of those 2 things, tib-fib instability or asymmetric hyperextension, I'll do a full Laprode. If they don't, then I like to do Arciero's technique, which is technically a little bit easier because you don't have to drill that hole in the tibia. So I think understanding the anatomy is key, and I think Laprode's work there has actually been huge to define that anatomy. Knowing where the fibula insertion is of the FCL. So essentially if I do an Arciero, I'm going to do a single graft, FCL insertion through the fibula front to back and then back to the popliteus. I will put a screw in the fibular head that allows me to independently tension the 2, and then I will fine-tune the tensioning on both those different flexion angles.
Got it. MEAC Orthopedics is leading a shift in the treatment of anterior cruciate ligament tears, from reconstruction to restoration with the Bair implant. Bridge-enhanced ACL restoration facilitates healing of the torn ACL. Unlike reconstruction, the Bair implant does not require a second surgical wound site to remove a healthy tendon from another part of the leg or the use of a donor tendon.
The Bair implant acts as a bridge between the 2 ends of a torn ACL. The surgeon injects a small amount of the patient's own blood into the implant and inserts it in between the torn ends of the ACL in a minimally invasive procedure. The combination of the Bair implant and the patient's blood enables the body to heal the torn ends of the ACL back together while maintaining the ACL's original attachments to the femur and tibia. The Bair implant is resorbed by the body as the ACL heals.
To learn more about the Bair implant, including clinical study results and instructions for use, visit www.bairimplant.com.
Yeah, so when we're talking about the posterolateral corner, Laprode's done a great job helping demystify a lot of this, and I love Armando's technique, but to kind of demystify, to make it a little less overwhelming, most of these are LCLs and not a ton of popliteus, so you don't need the 4 tunnels. But if it's an LCL, it's 1 tunnel for me in the femur, 1 tunnel in the fibula, and that's it. Cut the graft in the back of the fibula, you get it anatomically reconstructed, the tunnels are anatomically placed, and that's, so basically I've done the Laprode, and it's tensioned at about 15 to 30 degrees of flexion with a little bit of valgus and a little bit of internal rotation. And so with that, the knee comes back really, really nicely. But the selective tensioning is also a really nice way to do it, especially if you have more tunnels. But tib-fib instability, which is completely under-recognized, there's the MRI never picks it up, almost never. And so if you're doing MRI medicine and not physical exam medicine, you're going to miss it. And having that shuck test side to side on the fibula and having a high clinical suspicion for it, then we're going into the tibia as well. And almost by definition, the LCL is probably stretched in that manner because the fibula has been translating 8-10 millimeters front to back throughout the time.
Yeah, agreed. One thing I'd add too is I've gone to using suture augmentation for a lot of my collaterals. I don't know if there's any evidence for that, but certainly for my medial side and lateral side, I'll do some sort of suture augmentation to act as a brace while it's during that healing phase.
And I'm going to pin that for when we get to rehab because I have some questions about that.
The PT in you.
I know, I can't help it.
I knew it was coming.
Yeah.
It's always there. So, Matt, you've been, obviously within the military, back when Ashley and I were both at MGH and at Steadman, you've done an extensive amount of training of individuals in how to operate. So I think it'd be really helpful for people to hear your pearls. So as far as when you are attacking the posterior lateral corner, what are some things that you've sort of either changed, evolved, or created over the years that you can share with people?
Yeah, I think number one is just knowing the anatomy and practicing. There's structures there you obviously want to be careful of. The first thing is making the incision in the right place. It's an incision that I make at the knee bent at about 30 degrees, so it's not a straight inline incision if the knee's fully extended. But it's really centered from distally between Gerdy's tubercle and the fibula head, and then almost over to the lateral epicondyle. And so if you have that, when maybe an extra centimeter on either side, it's going to afford you a pretty nice opening. Now, if you're doing this, you got a huge knee, you got all the, don't be afraid to make longer incisions. That's first. And you can titrate that down as the time goes. Second, identification of the perineal nerve. And so it always happens. It can be tough. And Armando and I, we had a case last year. It was super scarred in. It was brutal. But just the nerve part took probably an hour. And you get some of these revision situations other times. Those can be really challenging. But the perineal nerve is key. I use a vessel loop. We just put it on very loosely. We don't use an instrument on it. And then we start identifying the anatomy and the surgical landmarks.
Yeah, those are great
Absolutely.
tips.
So I do want to talk before I'm going to skip ahead if I want to leave rehab for you.
Yeah.
So we want to talk about getting patients back to their pre-injury level of activity. First, is that possible? How do you counsel people based on their initial injury? These are pretty severe injuries in terms of what they can expect in terms of their ability to get back to, let's say, high-level skiing.
Yeah, I think it's a good question. I mean, these are not ACL injuries, right, where the expectation, the bar is so high. I tend to lay a lot of crepe. I mean, I think there is an ability to get patients back to a high level of functioning. I think the more ligaments that are injured, the less predictable it is. And I tell them that. I said, we're not perfect with our ligament reconstructions. They're all each imperfect in a subtle way. And you add it, just an ACL slightly imperfect compared to what God gave us is one thing. And then you add a second ligament and a third and a fourth. So I do think there's a capacity to get back to a high level. I think it's a year to year and a half recovery, as Catherine was indicating earlier. But I lay a lot of crepe that this may not be a knee that lets you get back to that level of function. I tell them I'm not setting the bar lower. My goal is still to give them a knee that lets them do everything they want to do, but I try to set realistic expectations.
100%. You have to, the expectations have to be outlined on this injury. The entire soft tissue envelope is injured. It's stressed. It's strained. To get back to knee homeostasis baseline, it takes a long time, and they may never get there. And I always say you may need tune-ups on this knee going forward. This is probably not your last surgery. It's not your last intervention. These are big injuries. You may need a scar debridement 20-30% of the time. You may need something else. You may need cartilage, meniscus, whatever. I don't know what that looks like. You might need a revision ligament. But this is going to be the best way going forward to you to try to get back to your activities. And in general, we're pretty successful. But obviously, there's a huge component of rehabilitation. The mental side of this is massive, among many other things.
Absolutely.
Yeah, so I'm going to start with the easy stuff with rehab. So
can you just tell us what to do?
I know. Exactly. Can I phone a friend?
Yeah.
the bracing side of it. So I think, that's relatively easy. Do you both start with a hinge sort of brace?
Yeah, I'll start with a
You're
hinge
not doing
brace,
that?
and
Okay.
and if there's a PCL, I'll switch into like a jack brace or some
Okay.
sort of PCL supportive brace later.
And then as far as, as you move into a more functional brace, are you starting to do more ligament specific? Are you, like you mentioned with the PCL type brace, are you thinking a little bit more about unloaders? How do you problem solve these things?
It's a good question. I mean, I think it depends on the combination of injuries. So unloaders, that can actually be really helpful to protect the ligament reconstruction, assuming it's just one collateral that's out.
Right.
You know, if they're both out, then you're kind of hosed. But it's so I actually
But it can hose you. It can hose you on the other side. You know,
Yeah.
Good.
stretch out the other side.
Yeah, it all depends on what their underlying alignment is too. Like actually, I just right before we came here to Denver, I did a PCL, MCL, and he's natively in varus. It's going to protect me. It's actually great for that particular injury. So I won't put him in an unloader brace. But patients that are neutral or aligned in the opposite direction, I think unloader braces can be really helpful.
Yeah, agree.
Yeah, some type of functional brace. I don't think it's 100% mandatory, and you know, I find that a lot of these patients just self-guard, self-select themselves, and the evidence just really isn't there to 100% support. But I still like using them. I like it. I think it's helps them. I try to use it the first year after surgery.
Yeah, agree. I usually tell people, you know, once they get to that year mark, it's really just up to them. You know, sometimes people are like, I just feel better or, you know, more confident. And even if that is a placebo type thing, there's value to them feeling confident, and that's going to change the way they have fear of re-injury and all those sorts of things.
Yeah.
So my question that I want to pin, so we had Brett Owens on, and we were talking about MCL injuries, and there was this one paper in the rehab protocol who was talking about if you have a suture augmentation to a reconstruction, then you can weight bear right away. And when I went back and looked at the study and really tried to find where did that come from, it just seemed to be an anecdote. But it was published as if it was, you know, gospel.
Dogma.
That never happens in our
So
literature.
I know.
Right,
So,
right.
what are your thoughts as someone who is finding value in suture augmentation, Armando? What do you think about that? Does that help?
Well, I would say so. As a caveat, I would say I love to be able to let patients bear weight early if they can. Right. So, and I think for collaterals, sometimes you can do that in extension, maybe not through the full range of motion in a brace. I don't think that a suture augment changes that, though. I don't trust enough that suture can withstand weight bearing. So that doesn't change my philosophy on that. It certainly doesn't allow me to be more aggressive with rehab. It just allows me to feel that I have some protection as they're going through that rehab process, but it doesn't change my rehab at all, at least not personally. I don't know about you, Matt.
Yeah, it's about the same. I mean, maybe you'd sleep a little bit better at night, but we gotta get the biology to heal.
Yeah.
We gotta get back to homeostasis. So I still treat it about the same.
Yeah.
Now, are you
Go ahead.
asking me? Or
No,
is
no,
it-
no, 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 I'm not.
I was like, those were good answers. I agree with all of the above. No, I was going to more ask in terms of internal brace augmentation, because when you brought up Brett Owens, I thought you were going to bring up this, where isolated MCL repair, I usually do add an internal brace, and I was shocked that both you and Brett do not add that. So I'm curious, I know we're talking about multi-legs, but are you typically adding suture augmentation for all ligaments, even if it's isolated, like an isolated ACL, MCL, or are you only doing that in the case of multi-leg to add some stability?
I'm really just doing it in the cases that I think I have a high propensity to stretch out a graft, right? So, Bruce Levy's looked at it for PCL, and they had about a millimeter decrease in their kneeling stress x-rays, and there's value. I think we all accept that our PCLs tend to stretch out a little bit. They don't feel as good as when we put them in the OR. I do think there's value in the collaterals as well. I don't do it routinely for my ACLs. I know that these are very controversial topics, because I don't feel like my ACLs are undergoing that kind of elongation during the recovery process. So I do it for all PCLs. I do it for MCL recons. I just incorporate it into my graft, and I do it for the FCL portion of a posterolateral corner.
So the other thing, as far as recovery, mental side, Matt, you and I have an aligned interest in this area. So if you could share a little bit about, especially with your military folks, they're going through these big traumatic injuries, they're being taken away sometimes from their team. How do you deal with that, and what do you recommend for them?
Yeah, so Catherine, you bring up a really good point on the mental health side, and whether you look at resiliency scores or ability to have the recovery tied into your mental capacity to do this is completely understudied, and we need to do more with that. It's super important, and it gets even more important with a multi-leg knee injury. I found more and more. These can be super devastating injuries. People think their career's over, their weekend warrior skiing's over, their mountain biking, their hiking, their golf, everything. Their whole life is done. Yeah, their complete identity is gone. So working with that and working with sports health, psychology, psychiatry professionals, I think is super important. But we also have to coach a lot too, and that's why it's not just orthopedics. It's orthopedic sports medicine and coaching our patients through that is really good. I do think we're AOSSM developing additional training modules in this. There's more to come on this, and I think this is going to be super valuable for all of us in our profession going forward. The problem is it takes time, and we're all at a commodity of time, and we have to really look at our patients. Armando and I, we share a lot of patients, and we look at the capabilities of them to mentally deal with this tough injury, and we want nothing more than to help them and get them back and go to the next level. But you just like, I'll see Armando walking by my office. He's like, I just spent 45 minutes with this patient. It was a lot, but it was super worthwhile because I think we got a breakthrough. And 42 minutes of that was dealing with the mental side of the game.
And I think, to your point, it's almost like, the surgeons dealing with these types of complex injuries could also use some coaching too, for themselves, and sort of saying, how do you break down all these steps, realize that nothing is always perfect, and that it's like a very human thing to make some certain mistakes along the way, or it's a hard population.
And
surgery's tough. I mean, it is stressful on us. These are hard cases. You want them to do well. They come back and they have 45 degrees of knee flexion at 2 months or 3 months. Armando looking at me like, what do you want to do with this one? And when do we manipulate? When do we scope? When do we give Indocin? When do we inject? These can be and these patients are with you a long time, which is great. They've entrusted you to their care, but there's a lot of stress on both sides of the equation to get this patient back.
Yeah, if you remember with Joe Hannafin, do you remember we had Joe Hannafin on at one point, and she was talking about post-retirement. And I can't exactly remember how she phrased it, but she said she slept through the night for the first time.
I've heard people say that.
Yes. Yes.
Yeah.
But I do joke that we're part-time psychiatrists. I think it's a big part of it. Like even if it's just simple ACLs and these adolescent kids, that's a big part of getting them through the whole journey of this injury. The surgery is just part of it.
It's interesting. Rondo's office is 2 doors down from mine in Vail, and I think we probably talk more about the mental side of our patients and how to help them and what would you do, and here's the situation, here's our social, here's our sports situation, here's what they got to get back to, what would you do here? It's not like technique. 2 millimeters on the tunnel here this way, which it used to be, but it's just where we kind of are in our practice now. But I think we have to be doing that earlier, and I wish I had that earlier in my practice.
100%.
Well, I think what I hope for the future with this psychological aspect, and maybe the two of you and anyone else who's studying this is going to solve this, is an ability to identify patients that are going to struggle preoperatively. And we've talked about that grit paper that was from AJSM, looking at patients who had preoperative, high grit scores, did better postoperatively after ACL.
Absolutely.
The ability to identify those patients, or probably more important, identify patients that don't have that grit and be able to intervene earlier with psychological assistance, I think is really important. So we have a lot to learn here, but I think it's only going to better our patients.
Yeah, I think we could learn a lot from our arthroplasty colleagues. They're actually way ahead of us in this in terms of looking at psychosocial factors and a prediction of how they're going to do from surgery. Now, obviously, their surgeries are different because they're chronic, they're not urgent, it's not an acute injury, but they've actually looked at this quite a bit. It's remarkable how they can intervene early to achieve a better surgical outcome for some of these patients that score poorly. They're way ahead of us.
Yeah, we're doing terribly. Yeah.
We're going to catch up.
We're catch up.
We're getting there.
Dr. Logan's all over it.
Yes.
Trying.
Awesome.
Yeah. No, this is fantastic. You guys, are... we were so excited that you both agreed to come on and you came on together. So it's always nice and valuable when there's a good rapport between two people.
Yeah.
We certainly learned a lot, and we know everybody else did as well. So thank you for sharing your time with us. We know it's very valuable.
Yeah, thank you very much. It was awesome.
Yeah, well, thank you guys. This was great. This is really super fun. It's always fun to do it with Matt.
Yeah, absolutely. Catherine, Ashley, thanks so much. And it's great to have Armando here as well, because it's fun to have a great friend and a great partner to go through this journey together. So thank you for what you're doing as well. We appreciate it. Thanks.
Thank you.
Thank you.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.